So thank you to the Moldovan Pain Society for the invitation to speak today on assessment and management of chronic musculoskeletal pain. My name is Catherine Doody and I'm based in University College Dublin, that's in Ireland. So I'm speaking to you today from Ireland. It took me a while to find a map with Ireland as the centre of the universe, but here we are. As you can see, we're on the very west of Europe. Next place on our latitude would be Newfoundland. So we have the large Atlantic Ocean coming in across Ireland, dumping all the moisture on us, which makes our island very green. And also we get a lot of rain. But here we are. This is the Health Sciences Centre in UCD, where I'm based, where the sun is always shining, as you can see. So today's talk on chronic musculoskeletal pain assessment and management, I'll speak about chronic musculoskeletal pain from the perspective of a biopsychosocial approach to both assessment and management, also with reference to the newer terminology changes in the ICD-11 and also the International Association for the Study of Pain, recent pain terminology changes. As implicit in some of the recent changes to terminology is that we consider maybe looking a little bit more at pain as an entity in its own right. So we may consider using some aspects of pain mechanisms assessment in our assessment and considerations for treatment. And finally, I'll speak a little about what the current evidence says about treatment of chronic musculoskeletal pain. So we know that chronic pain is a considerable problem. In Europe, we have an incidence of chronic pain of approximately 20%. For musculoskeletal disorders, we have chronic musculoskeletal pain of about 13% in Denmark, and variations in data on this, like in the UK, they say between 15 and 50%. I think this is to do a little bit with how it's classified and described. This data here on the slide is from the Global Burden of Disease Study 2017, with just the musculoskeletal disorders data taken out. So it's giving incidence per 100,000 population by age and sex. And we can see here that we have an increasing incidence as we age, and increasing incidence for women as opposed to for men. Again, from the Global Burden of Disease Study, just with musculoskeletal disorders, we can see here on the diagram in green, the single most biggest cause of chronic musculoskeletal pain would be low back pain. So that's in green. And also following on from this, we have osteoarthritis, neck pain, then we've gout, rheumatoid arthritis, and other musculoskeletal disorders represented in there. Actually, in the first diagram, as we can also see the incidence in Western Europe and in Central and Eastern Europe here, which are quite similar, really. And the second diagram then shows again, over the life course, that we have increasing incidence, particularly of osteoarthritis as we age, and low back pain tapering off a little, and neck pain. So how do we then start to classify and consider and assess chronic musculoskeletal pain? So we know that chronic pain has traditionally been defined as pain that persists for longer than 3 months. People have different classifications and ways of describing it. This is a very common one. And in the recent ICD, International Classification of Disease 11, there is a new category for chronic primary musculoskeletal pain, which is considering primary pain as being an entity really in its own right. And then we also have chronic secondary musculoskeletal pain, which would be secondary to a specific disorder, maybe chronic low back pain or osteoarthritis, as we mentioned. However, It's not completely straightforward, I think, as most things are not. This is the ICD-11 classification for chronic pain. And we can see on the left, we have chronic primary pain, and on the right, we have all the chronic secondary pain syndromes. So in here, then, we have chronic primary pain at the base here and chronic secondary pain, musculoskeletal pain. And we have overlap between these. So we can see they have a double arrow, and I have just overlapped them here together, as this is an issue, I think, probably the next thing which will be researched and defined further following these new classification systems. So how do we tell if somebody has chronic primary musculoskeletal pain or chronic secondary musculoskeletal pain, and how do we tell if it's one more than the other? And the answer is we're not really sure yet. There have been some recent publications proposing, or one in particular, how this might be done, but it does require further empirical validation testing in order for it to be to validate this, really. So also just to note here that there's an arrow going, a double arrow from chronic secondary musculoskeletal pain up to chronic widespread pain, which will include fibromyalgia in there. So there's considerable overlap here, really, I think, is the message. But I feel that implicit in these new classifications, particularly for chronic primary pain, is that we consider a little bit about the underlying pain mechanisms that may be responsible for the generation or maintenance of a person's pain presentation. So when considering assessment of people with musculoskeletal pain, then we know that we need to use really a biopsychosocial approach. We're trying to understand really and quantify as best we can and describe a person's overall pain experience. So using a biopsychosocial approach, we can consider maybe basic pathophysiological processes, maybe disease processes, physiological processes under the bio part of the model. And then we can also consider the affective components, the effects on mood, overall suffering for the person, social aspects, participation issues, behavioral effects of chronic pain, in addition to considering and assessing sensory aspects of pain. So we know that living with chronic pain is really a significant challenge for individuals. And so it's important to try and understand this, really. And the other issue about the biopsychosocial assessment is, although these issues can contribute to a person's pain experience and will be in their descriptions of their pain experience, these associations can be bidirectional. So in other words, management that can promote resilience, understanding, support, increased participation, engagement with life, increased function, can help to reduce the impact of pain and maybe have some effects on the overall pain experience and maybe on the pain itself, but that would be more secondary normally. And then how best to do this type of assessment? Well, there are some very good guidelines from the Initiative on Methods, Measurement and Pain Assessment in Clinical Trials. That's the IMPACT guidelines, and they suggest looking at 6 domains altogether to cover the multidimensional aspects of the overall pain experience. And I like this one from the British Pain Society, where they have this on their website. There's a little PDF you can download, and they have summarized many or translated many of the IMPACT guidelines into quite a short and easy to use booklet. And in this then they have the pain dimensions and then the corresponding outcome measures. So they suggest looking at pain quality interference, physical functioning, emotional, social functioning, quality of life, and then overall patient reported global ratings. This is the patient's overall assessment quantified of their current pain experience. And looking a bit further into these methods, then most of these are patient reported outcome measures. So you're depending on the patient's report here, they can patients can fill these out themselves or can be done in association with their clinician. And these are covering all of the dimensions really of the biopsychosocial assessment of pain. So for example, here from the British Pain Society, the brief pain inventory would cover pain quality and interference together. So some of these measures cover many different dimensions of the biopsychosocial assessment. So we may not need separate ones for each one, depending on the patient, or if it's for a research study, depending, again, we won't need all of these. And I suppose, unfortunately, in both the clinical and research communities, we don't really have an overall agreement internationally on what would be the best measures to use. So they all measure the different dimensions of pain, but we have many, many different outcome measures. So that makes it difficult then to amalgamate data. It's a little bit trickier if people are trying to do reviews or meta-analysis of these data, or indeed if they're trying to come up with guidelines. So in this here as well, we also have, you can see, assessment of pain mechanisms, and this links back a little to the changes in terminology and maybe viewing pain is in a little bit of a different way. So we have patient-reported outcome measures also for central sensitization syndromes. Originally, this was designed for, it's the CSI. It has a cutoff score for central sensitization. And we also have many measures for many years for neuropathic pain, like the LANS or Pain Detect. And then we can also use techniques like quantitative sensory testing. QST, as it's known for short, are graded noxious or non-noxious stimuli, which are going to assess overall somatosensory function. There are some simple measures we can use as an add-on really to clinical assessment. To look then, if we're thinking of including a little bit more on pain mechanisms in assessment and considerations for treatment, just reviewing again, I know you've had some lectures today on a classification, but briefly reviewing again just pain mechanisms terminology. We have three main categories of pain proposed by the International Association Study of Pain: nociceptive pain, the one everyone's most familiar with; neuropathic pain, again, just pertaining to a disease or lesion of the somatosensory nervous system only. And then the more recent terminology change was in nocioplastic pain, where this is basically saying that there is a certain degree, a break in a link between nociception and pain perception, or stimulation of nociception and pain perception. So there may not be any discernible tissue damage causing activation of peripheral nociceptors, and still the person is complaining of quite significant symptoms of pain and other symptoms also. So again, I think these terms are all a little bit different, and they are terms that are evolving. And the other big thing about these definitions here is that there's a mixed, an assumption of mixed pain states, pain mechanisms in different individuals presenting with pain to your clinic or your research study. So there may be mixtures and components of all three of these, or maybe two, or just one. So if we were considering using quantitative sensory testing, to note that although they're called quantitative, they are psychophysical measures. So we're really asking the patient's response to the application of calibrated, graded, noxious or non-noxious stimuli, but it is the patient's response to that. So we can quantify it to a degree, but there are still patient-reported measures to a large degree. They can be useful in assessment, give us some more information in relation to pain mechanisms. They're not telling us where a specific lesion or problem is, so they're quite general methods, but they can, there is some evidence that they can be helpful as predictors of outcome of treatment or monitoring treatment, and can show us differences in nervous system function really and pain processing between people who have chronic musculoskeletal pain and those who don't. So 3 simple measures that can be used really at bedside are pressure pain thresholds to measure hyperalgesia, and this can be done with the pressure algometer, which will give a readout in kilopascals, or other force pressure measure rather. Temporal summation, which is assessing enhanced central nervous system activity, and this will can be assessed with a weighted pinprick, for example. There are other ways of doing all these tests, and I'm just pulling out 3 simple ones. And then thirdly, we can look at conditioned pain modulation, which will assess the descending pain pathways. So with this method here, the third one, we are applying a noxious stimulus, a conditioning stimulus to a part of the body. In this case, it's the hand submerged in a cold water bath to 4 degrees. We apply PPTs, pressure pain thresholds, pre and post the application of the conditioning stimulus, and we would expect the pressure pain thresholds to have increased. So pain perception should be the perception of pain should be lessened really after activation of the descending pain inhibitory pathways, and this can be dysfunctional, in which case the opposite will happen. So with hyperalgesia, firstly with pressure pain thresholds, we're looking at a shifting really of the threshold for perception of pain to be moved to the left, so it'll be decreased. With temporal summation, we're applying a barrage really of impulses to the nervous system. This could be a weighted pinprick, so it's a noxious stimulus really. It's activating C fibers, barrage of C fibers to the dorsal horn, and this is the physiological phenomenon of wind up. So we will get enhanced feeling of pain from repeated stimuli with excitation of the nervous system, increased excitation. And then thirdly, with conditioned pain modulation in an intact state up here, we would expect there to be some kind of increase in the pressure pain thresholds, but this may be impaired in some people. So it's telling us a little bit about pain mechanisms, and there have been extensive work done by our German colleagues looking at quantifying and describing these huge somatosensory profiles of people and normal data for database and standardization of these measures. So I'm just pulling out 3 which might be useful more in a clinical setting. Some research around these here that we can see in this systematic review of 25 studies with people with low back pain compared to healthy controls had significant decreases in pressure pain thresholds at remote sites, not in the back, but remote sites of the body compared to control. So indicating there's some kind of sensitization or excitation in the nervous system, and also increased temporal summation at the local site, but this wasn't as consistent across the studies. And the results for CPM, conditioned pain modulation, were very mixed. So they didn't make any conclusions about those from their meta-analysis. In this large systematic review on the left here, this was a review of 37 studies looking at the predictive capacity of QST. There were 15 studies of OA, 15 for the knee, the neck, 6 low back, 3, and they were able to include 34 in the meta-analysis altogether. So they did find that pain hypersensitivity, as quantified by sensory testing at baseline, was associated with poor outcome in all of these studies. For pain intensity in 30 studies, for disability in 11 studies, so poor outcome for intensity of pain, disability, and negative affect in 3 studies. And this study on the right here is one we did in UCD a couple of years ago. We looked at 156 people with moderate to severe osteoarthritis pain of the knee. And we did find that higher temporal summation and lower pressure pain thresholds emerged as robust predictors of non-response to physiotherapy programs. So there is some evidence that they may be a little helpful in predicting outcome, but the results are a little mixed. Just the same, it's worth bearing in mind. So how might we, the various categories that are proposed by IASP, for example, nociceptive, neuropathic, nocioplastic pain, how do we recognize these clinically? And this is the difficulty, really. I think it is, there is no international consensus or gold standard for doing this as yet, but it is emerging, I think, and the research is continuing and the papers coming out on this. So in this study here, this group did a large Delphi study for 49 experts from 15 different countries to ask them what they thought represented nociceptive, neuropathic, and nocioplastic pain. And following rounds of the Delphi survey, there was broad agreement for a few main signs, symptoms across these three categories or classifications really of pain. There were 17 altogether for nociceptive pain, but there were 3, as can see here, like responsiveness to non-steroidal anti-inflammatories, signs of inflammation, predicted pain recovery based on expected tissue healing time. And for neuropathic, there were 37 different indicators. And again, these were largely based around assessment of nerve damage. Nocioplastic pain, 22 different ones, but 3 or 4 main ones, including diffuse, widespread, poorly localized pain, general hypersensitivity, however it is assessed, multiple somatic symptoms like fatigue, sleep problems, memory problems. And then the other one is a mixture of all of these. So mixture of neuropathic and nociceptive with 78 indicators, nociceptive and neuropathic 27, and neuropathic and nocioplastic, sorry, I think I'm getting a couple of these, 17. So they were quite mixed for the mixed ones also. So it's tricky how to do this clinically. So overall then, a biopsychosocial assessment is merited for assessing a person's overall pain experience. So we're really trying to understand how all these different dimensions are affecting pain, and remembering that it can be bidirectional, which is what is useful for management of pain. And considering some consideration of pain mechanisms, I think, is useful, particularly in light of the new classifications of disease, both from the ICD-11 and the IASP classifications. So following all this then, how do we manage chronic musculoskeletal pain? So I'm going to review briefly now the clinical practice guidelines for chronic musculoskeletal pain, some specific ones, recent systematic review, which pooled numbers of these together, and then look at a couple of reviews for evidence-based guidelines, as evidence in physical activity appears in all of the guidelines. It's one thing everyone seems to agree on. So firstly, here are the NICE guidelines from the UK for both assessment and management. I'm just going to focus on management at the moment of chronic primary and secondary musculoskeletal pain. Now, they do have specific guidelines for different areas. So all the different conditions we spoke about earlier, for example, low back pain or neck pain, which come under chronic musculoskeletal pain. But in the overall guidelines for chronic primary and secondary musculoskeletal pain, they're saying really they're promoting exercise and physical activity programs. Within that, they're not making recommendations about specific exercise programs because the evidence is quite mixed as to which is best. Psychological therapies, they are recommending in particular acceptance commitment therapy and CBT, acupuncture also, and then pharmacological management. And just to note here that they don't recommend pain management programs explicitly in these guidelines. And that's an intervention with 2 or more components, usually including a physical and psychological component delivered usually by trained trained health professionals. So not recommend, they're splitting them up. And these guidelines have been some criticism of these guidelines for this. And also I think for being they're quite explicit about ACT and CBT as opposed to other psychological therapies. Other guidelines from the UK, from the Scottish guidelines, which are all island guidelines as well. They have a little bit broader in their guidelines, and they're including more about supporting people to self-manage. That's a big thing here, pharmacological management again. And then they do recommend pain management programs, exercise and physical activity, and advice really to stay active. And just to note here, they mentioned this here, I'll just come back to this towards the end again, the clinicians should be aware of the possibility that their own behaviour and the clinical environment can impact on reinforcement of unhelpful responses. And I think what's useful about this is the clinician can impact for helpful responses for the patient also. And this is really good to know, I think, and I will just show some research about this at the end. It's always great when you come across a systematic review where somebody's put everything together for you, as is the case here. So this is a recent review of 44 different clinical practice guidelines were appraised, and they have included in their recommendations 11 of these guidelines as they were deemed to be high quality guidelines. And these were 4 on back pain, 4 on OA, 2 on neck pain, and 1 on the shoulder. And coincidentally, they all also came up with 11 recommendations. And they're saying that we should use patient-reported outcome measures to evaluate progress, providing information and advice again, and education, physical activity and exercise, resumption of work or continuation of work, non-surgical management always prior to any surgery. However, there may be instances where absolutely surgery would be indicated depending on the individual condition. So these are high-level guidance, but the messaging is pretty clear in terms of education, advice, exercise, physical activity, and of course pharmacological management, which I'm not addressing in this talk. So just pulling out then about exercise in particular, because it is in all the guidelines, and I guess it's my interest from a physiotherapy perspective. In this big Cochrane review of physical activity and exercise for chronic pain, for 21 reviews, approximately 20,000 participants when all the data is combined, conditions including low back pain, OA, neck pain, fibromyalgia, and others. They're saying that there are some favourable effects for reduction of pain and maybe function, but they're small to moderate in effect sizes. Maybe mixed results more for psychological function and quality of life. We don't know what intensity, duration, and frequency in terms of exercise is best, and these really need to be researched further. And for low back pain, then exercise guidelines, again from Cochrane, 249 trials here, 24,486 people altogether when you amalgamate the data. And most of these studies would measure pain and disability. And they find that exercise is probably more effective for pain than no treatment, usual care, or placebo for people with chronic low back pain, but they can't make specific recommendations again. So we need to do more research as to what works best for different groups of people, what types of exercise, because these types of exercise included in these studies would include everything from resistance to flexibility, to yoga, to Tai Chi, to walking programs, etc. So I guess most importantly, to consider finally, what do patients say about self-management type interventions for chronic pain? So at this large review here of 27 qualitative studies where they're using qualitative data analysis and methods of collection to understand from the point of view of the participants themselves or people with pain, participants in the study. So it's 487 participants. So what facilitates or impedes self-management? And so the patients are saying that a big thing here is the healthcare practitioner. So like what they're saying in the Scottish guidelines, the healthcare practitioner is really important from the patient's perspective. The healthcare practitioner can influence the patient to facilitate the patient to come to a place of acceptance, increase self-efficacy, improve people's knowledge and understanding of pain, and be a support person for somebody trying to manage a challenging long-term, maybe lifelong condition. And similarly, the healthcare practitioner can negatively impact on that, as well, as the Scottish guidelines are telling us, and reinforce internal barriers to like non-acceptance and low self-efficacy. So poor communication between healthcare practitioners then and patients can really reduce understanding of the benefits of self-management. However, good communication between both can improve acceptance, self-efficacy, and help people to set their own goals to facilitate change in their lives. And here are just some of the quotes from the patients in some of these studies. In grey here, I thought this would be suitable for colour for things weren't going so well. That, you know, people feeling they're not being trusted and not validated, and they're not being believed. That they would like to set their own goals. Like this case, the healthcare practitioner seemed to think the patient wanted to be able to hoover, but they didn't. Who would want to be able to hoover? I don't know. Maybe it's a goal for some people. And on the right here, then, this is when it goes well, that the patient is saying, obviously in the first one, the healthcare practitioner listened really well. She guided her to a solution, or another person the healthcare practitioner explained what to do. She could see what to do herself. And then, having learned all these things, the next step then is to learn to live with the condition. And this is a nice quote here, I think, which summarizes nearly everything I've said. And it's from the Lancet. There was a series of articles in the Lancet, Rethinking Chronic Pain, in 2021. And the editorial here is saying, a strong therapeutic alliance is critical to help people understand. So it's education, shift expectations, helping people set realistic individual goals, and prioritizing function and quality of life, considering this bidirectionality in the whole biopsychosocial model, as opposed to a focus on pain relief or complete pain relief. And then reassurance and support and validation for people is really, really important. Support them through their pain experience. And the biopsychosocial approach is a great model to use for assessment and treatment, and then also consideration of pain mechanisms in assessment, and can help inform treatment within the overall biopsychosocial approach, and within the context of the change in terminologies and that all that brings with it for our understanding of pain. And thank you.